All right, page 225. My last topic for you guys is dealing with some new widgets and gadgets. It's put together by Al Sacchetti. I don't have hands-on experience with all of these gadgets. A few of them I do. Before we even start talking about them, I just got to talk a little bit about the literature of new gadgets, which is the first tier of literature is usually created by the inventor or the investors. So they got to, and it takes a lot of money to get a gadget approved and released for use. There's, new device approvals and things like that there's a lot of upfront investment in that. I've had a couple of my graduates over the years who've successfully created widgets and gadgets, and I've participated in some of that stuff. So it is a real effort. The second tier of literature on those is usually sponsored trials where they have to give the device to somebody to do it, but the people who are doing the research aren't owners or investors. And those are usually pretty biased as well. Obviously, you don't give the device if you think that people are going to misuse it and make the thing that you've been laboring on for 5 to 10 years of your life look bad. And then finally, there's a third tier of research. Most of the devices we're talking about are barely out of the first tier, but the third tier is when independent people start looking at it and saying whether it does what it's purported to do and how good it is. So the bottom line of what I just said is when you see the new widget hit the floor and there's a couple papers on it, you got to look really carefully at those, and a high degree of skepticism is involved. Often the financial analyses, there's some financial analysis about how this is going to be great for the system and things like that. That often does not pan out also when you look at it, because they're sort of set up, like the new antibiotic, to compare it to 2 days in the hospital, where they may or may not need that. Having noted that, there's some interesting stuff here that's kind of fun. The first two are the Sonic Window, and the Vein Light LED-X. These are both little widgets, and the first one's 10 grand, and the next one's also pretty pricey little deal, about $1,000 by the time you're done with it. And what they do is they find veins for you. Well, that's a real problem. We've all seen fat people, little people, round people, scarred people, pimply people, dark-skinned people, where we can't find veins well. And so finding a vein, which, access is a pretty important thing in emergency medicine, although there are lots of papers that say we access way more people than we ever use their access for, particularly in the field. But having noted that, something that made access better, I'm all for. I mentioned that I'm in an ultrasound sort of kind of community in the emergency room, and we use our ultrasounds, our linear probes, to find veins all the time. We've trained the nurses to do it. And so the first widget looks like the kind of thing where it might be sort of exciting to get this and let your nurses loose with it, give them a little training, get them feeling like they have a better chance at finding a vein, because you know what the consequences of them not finding a vein, which is that you're either going to come in there and try an EJ or an ultrasound-guided brachiocephalic or a central line. So anything that would help them get further down the tree on a difficult stick would be something I'm all for. I don't know how successful these are. I don't have any testimonials from nurses. I know that in our department, where we use a standard ultrasound machine with a 10 megahertz probe, we have a lot more success getting peripheral veins in tough sticks. So in concept, good. I don't know how well this one goes. I spoke to someone who'd used the Vein Light the Vein Light, the second one, that said, this thing really makes you see veins that are just all over the place that you didn't appreciate, and that works. Again, I have certainly no financial interest in any of these, but also no experience with either of those. But I'm interested. I'm curious to see more. I like the idea of empowering the nursing staff with an ultrasound-guided device to improve their ability to get lines started. I like all that conceptually. 10 grand's pretty expensive, though, for the hand. It's pretty pricey. And what's going to happen with you got something like this? Wait till the drug abuse community finds out about that. They'll be like, what are you in the emergency room for? Well, I'm saying I have a dental problem, but I'm here to steal that thing. That's really what I'm here. I saw one of my friends who's got no access and has been skin popping. He's miserable, and I just don't want to go down the same road. I need this IV finder. I'm down to using my toes. But these things will walk. Most likely it's not going to be a patient that steals it. It's going to be someone else, another healthcare provider. We on our, we're going to look at some new TonoPens in a moment. We actually put a little, those printed labels, you see them on TV at 3 o'clock in the morning. Get organized in your house like you've been doing methamphetamine and are ready to organize your house tonight. The prints out all the labels. We print a label out and put it on it that says that it's low jacked, so that we'll know where it is when you steal it. It's not, but that label is a pretty good deterrent. So anything like this that can walk, I recommend you label it that this has a geographic information finder, and we will track it down to your bedroom if that's where it is. The next one, the VisiMobile cuffless BP monitor. How many of you think that the blood pressure cuff is a bit of a pain in the ass and can't we do something better? I do. But the one thing I hate is, the patient's got not great access, we're doing procedural sedation, or worse yet, they're just getting ready to do the RSI and the automated blood pressure comes up, occluding the line that I'm pushing the paralytics in, and maybe I haven't noticed that fact. So I'm like, why isn't the patient paralyzed? What's going on? I'm like, will you pull the blood pressure cuff off? So one that works on the wrist that doesn't have a cuff, this kind of is attractive to me because I've seen this blood pressure problem occur multiple times. I don't know if I'm paying $6,000 for it. And it looks like something that fits in a garbage can easily with the other trash that's being cleaned up at the end of the visit. So I don't know, but I like the idea again. There you have it. Not much more to say. No experience with it. Obviously we have these things that'll do heart rate, all kinds of non-invasive stuff on you now, and there is some role for them. But the blood pressure cuff is particularly, to me, a pain in the ass. Maybe not to you guys, but I like not having one on, blocking my access site, getting in the way. How many of you have seen a patient go to ground and be dangling by their blood pressure cuff, as they tripped over a dozen wires and stuff? I guess this is still one wire to trip over. The next one is this Vapotherm high flow humidified nasal cannula system. We talked about the paper with peds, saying that this is really helpful in peds with respiratory distress, that you can keep their SATs up. They tolerate it better than things like CPAP, BiPAP, and the little ones. And you can see this as I described it when we talked about it, a little jobber on wheels. $105 for cannula. You got to get the roly-doly thing and the widget that goes with it. That's not that's a more of a fixed cost, but $105 for cannula. I don't know what makes those cannulas so expensive, but there you go. But with this supporting literature that goes with this, we're more interested in this, and our pediatricians just got one because they love that paper. They think that paper is really, we mentioned this earlier, they think that concept is an important one, and so there you go. This creates the moist, warm nasal tornado as opposed to the dry desert tornado. Okay, that takes us to page 227. Another widget, which is the digital Broslow. So what this says is you got a patient, you Broslow them up, and you know what their weight is, and you're trying to calculate drug doses that if they just would enter that, for example, on the cow, the computer on wheels, which has a barcode reader, that any med you bring to the bedside, you just sweep it in there, it'll tell you the dose. So immediately doses it up. I think that sounds like a pain in the ass to me. I don't, maybe that reflects my computer fluency and things. But, most of my electronic charting doesn't have the bar scanner. Only the registration clerk has that. So that would mean putting the barcode reader on other things to make it useful for me. And the registration clerk isn't there during the whole visit. So, later on we're deciding on doses. I need that thing to get, so I'm just using the old-fashioned Broslow tape and doing that impossible math thing called multiplication, which I don't find to be that hard. So there you go. That one doesn't look that great. I don't know of anyone have this? Anyone using it? Any testimonial? By the way, if anyone has any testimonials on any of these things, I'm eager to hear them, and I'm sure the group is too. All right, the Perchik button down the bottom for puncture wounds that are bleeding and things, and this comes up with dialysis grafts. The other time you sometimes see, have you ever seen one of those varicose bleeders? It's like you just can't stop the goddamn, and then you make the mistake of saying, I'm going to put a stitch in it, and now you have 3 bleeders. Because one for each hole of the stitch, and the one that was there. And you're like doing things like putting a one of those biological dressings with with some Surgicel powder or other things underneath there. You're doing all kinds of stuff, and the patient's like, oh, I think it stopped. And as soon as they stand up and they have no outflow from their extremity, whoosh, whoosh, you're like, Jesus, this little pinprick of a bleed is occupying 2 hours of my time. So this Perchick button claims that it will do the trick. I'm still worried that the suture that you put in, it provides a little button of spot pressure. So I'm interested in this, but I have no experience to say it works. This might work on scalp bleeders. Sometimes you see those, they just won't stop, and you're injecting them with lidocaine and epi and doing stuff to try and get, stapling around it and doing things like that. And maybe it'll work for some of those. I can think of a couple situations where I'd like to try it, but before I was to buy a whole bunch of them, I'd like to know whether it actually works. But it looks like a good idea. It creates this little X that draws the pressure of the Perchick button down on the exact spot. We all know that direct pressure does stop most bleeding. And for example, with neck wounds and stuff, when people come in bleeding and they're bleeding all over the place and people are putting pressure, most of the problem is they're not putting their finger on the bleeding part. They'll almost always stop if you get the pressure applied to the right spot. And so, the challenge with this will be, are you accurate enough with your sutures such that when you cinch it down, it's putting pressure in the right spot, or is it putting pressure in the spot just next to it? So I don't know, because I've never used one, but I'm interested in that one. I think it looks kind of cool. That takes us to the NeoT infant T-place resuscitator, which is a device that replaces the ambu bag when ventilating infants. And gives good support. The size of the breath is determined by the peak pressure, not the tidal volume. So it's a pressured cycled vent, basically, kind of thing. Remember, many of you are old enough, not all of you, I can tell by looking out there, but how do you remember the old bird vents, those little green pressure cycled vents? They were about this big, and you could do pressured cycle ventilation for transports and things like that. I used to love the bird vents, and I remember a horrific, back when I trained at the county, and it was kind of a crazy place, you could, and I wasn't involved in this, but some of my classmates we had been calling for trauma surgery, they were in the OR, and they had their admitting service up on the 9th floor, and there was a designated elevator that went to it called the Bullet. And they put a fully dead guy in that elevator with towels underneath the wheels, so that when it binged on the floor, it would just roll out. And the guy was on a bird vent with a DPL catheter in. So this dead guy with multi-system trauma just arrived on the surgical ward. Bing! With the vent going. We thought that was just, now we would all been fired and taken off to jail. But back in those days, that was considered to be appropriate behavior, or even inappropriate then, but really comical. But this would allow you to have that kind of fun because it's a pressure cycled vent and they're really easy to do. So they say it eliminates the guesswork from ventilating newborns and infants up to 10 kilograms because you're going to be pressure cycled rather than volume cycled. And so you're also obviously going to avoid barotrauma. And I would just note that is overventilation, speaking of a recently intubated or managed patient of all ages, a problem? And the answer is absolutely. I help more intubated patients and more patients in our department who are receiving care because they intubate them and everyone's all ramped up and they're whoosh, 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 there's the bagger, and the patient's filling up like beginning to levitate off the bed like the Goodyear blimp, barely tethered because they're overventilated. I'm like, whoa. And then you manually exhale them and it sounds like a door closing. You put your hands on their chest and push on them and they go, and now they take another breath and their sats go up and everything's better. So people do overventilate. Even the American Heart had those little pins those little light pins that would go at 12 a minute, so you wouldn't overventilate in the cardiac arrest situation. And I would say when I'm working in our resus area, 3 times a shift, I'm like, whoa, slow down there. Don't overbag them, because when you overbag someone and increase their intrathoracic pressures, they get no cardiac return. Their cerebral perfusion, cardiac perfusion, all goes down. And so paying attention to these pressures is important, and that's what this is designed to do. But again, with wall oxygenation, you can do this with a resus mask, or with an ET tube, or with a thumb-controlled valve. So lots of flexibility for it. I just have no experience. Anyone got one of those? Interesting. I'm curious. Yeah, there you go. SAMs. Anyone got the SAM junctional tourniquets? Probably some of you have. Some you may, or you may not know the names. You know? So tourniquets have come back into vogue. So from the Iraq War experience, we now know that certainly for large vascular injuries that short-term tourniqueting saves lives, prevents hemorrhage. Most of these patients do, in fact, if they're going to die, bleed to death. I'm in a trauma center that sees enough gunshot wounds, and particularly sort of in this area or in the upper arm. The trick with the SAM is you got to be able to get it above it. And so some of these splints will sit better above those than others, but we use the SAM, and it's pretty good. Kenji Inaba, I mentioned he's one of our trauma surgeons at our place, published a recent paper on some comparison of the tourniquets, and they like some better than others, but the SAM product is a pretty good product. We now have them in the field as well for the paramedics to apply. So you may see people, even if you don't carry them in your department, you may see people arriving to you with a tourniquet in place, so don't be surprised by that, because tourniquets are back in for large vascular bleeds. I always love when you're told that it's, you know, over the radio or upstairs they call you, there's a carotid bleeder. It's never a carotid bleeder. You go up there and it's bleeding and there's blood. It's never really a carotid bleeder, except when it is. And I was working at some community ER where I moonlit, and the paramedics came there for airway extremis, so he should have gone to a trauma center, but it was a non-traumatic story. And what it was a guy who was born with some sort of hypoplastic ear. And so he went to the House Institute and they said, oh, we'll build you a new ear. So they pulled some flap of tissue off, like, I don't know where they got it from, back there, and it had some vascular stent because it wasn't quite long enough, and then they attached it to the side of his head, so he had this pulsating cauliflower on the side of his head. And they said, don't worry, we're going to make an ear out of that eventually. We just let that heal first, then we do the plastics part. And so he was in an Italian restaurant. They said, would you like a little pepper on that? Oh, yes. Anyway, yeah. And he didn't let it go. Huge pressure surge, and he exploded the thing off the side of his head. So everyone around him got extra sauce. So they called and they said, oh, we got a carotid bleeder. I'm like, whatever. We'll see it when it gets there. And so they arrive with this guy, and they're fucking strangling him. His head looks like a Pinot Noir grape. It's totally purple. I'm like, let go of him. They let go of him. Strangle him. Anyway, so I intubate him. We get direct pressure control on it. You know, we're transfusing him. He's lost a ton of blood. His pressure's low. We're doing all that. The surgeon comes in, and she's a bit of a bull in a china closet, but she responds, so I'm happy. Anytime they come, I don't care what the hell. You want coffee? You want to yell at me? I'll love it. You know, you're here. Anyway, so she comes in, she's stomping around, and she starts looking at this thing, and then she looks at this thing on the side, and she looks at me like I did it. She goes, what the fuck is that? And I go, I don't know. That's how he came in here. And now he's intubated, right? He's intubated, sedated, so he's not there to tell her I had this ear thing and all that. And she goes, I don't know what it is, but I'm tying it off. So the net outcome for him was a dead thing on the side of his head. Anyway, carotid bleeders. Usually not. But tourniquets, they're back in. They're back in. Get some. You should have them in your department. All right, the iWalk. I look at the pictures, and my comment is, yes, I can see you walk. You have this thing on that looks like it's a lot more dangerous and awkward than crutches to me. This looks like the prelude to a cervical fracture to me. I see this girl in the pink pants with the flip-flops on coming down the stairs with this thing, and I'm like, oh no! I want to run and to be there to catch her. I mean, it looks like one of those, those video shows where they show the cars crashing and the people jumping and I'm like, oh no, this is not a good idea. And it's only $149. They say this is great. I see the ones in the airport where they have the little scooter. That looks smarter to me. That looks a lot more stable. This thing.
But harder to use on the stairs.
Yeah, harder to use on the stairs. I'm looking at that's why they show her on the stairs, and it makes me nervous. the thing I like about it is the foot on the thing seems to be going backwards. That way you can be walking in two directions at the same time. But anyway, so they have that there for you. Anyone got these? Are you dispensing these? In my hospital, crutches are like $5. They're getting the crutches. There's no way we're getting these things for them. We have a guy, we still have him. I shouldn't say we still have him. He's an NSA, a needs special assistant patient at our hospital, who has discovered that when we dispense him a wheelchair, that can be sold. So whenever we dispense him a wheelchair, he goes out and he tries to do his abstinence thing for a couple of days, and he's like, hell with it. He sells the wheelchair. I don't know how much he's getting for him. I hope he's getting at least 50. But anyway, then he comes in, then he's found hammered, and he's unable to go anywhere because he's not in his wheelchair. He's got these decubitus, he's paralyzed. And so then he comes in, and because it takes a while to get a new wheelchair, he ends up in OBS. So, and this became a cycle. He's just like, I'm like, great, we've got Johnny Wheelchair Dispenser Appleseed here, who has discovered the market for selling his wheelchairs when he goes out. I bet he goes straight to the VA. I got a new wheelchair. What do you want? You want to upgrade? Anyway, but yeah, so these things do have some value out there. Does it look trustworthy? Am I the only person that thinks that doesn't look safe? Does it look? It looks unsteady. The strap around the thigh kind of bothers me.
It looks like a hair track.
Yeah, I don't know what it just doesn't look safe. I guess they got the guy there with luggage, If I had one, I could try it on the way out with my luggage, but there you go.
Can you read the description?
Says what? Yeah, well, indeed.
Seems like you can change the angle of where the knees are at.
Yeah, you could have a lot of scraping and chafing. I picture some high thigh irritation medially when I look at that. Without actually scratching a body part right now, I'll just tell you, yeah, that doesn't look right to me. How about the mainstream capnometer? Do any of you have little capnometers that'll do waveform and these other things? So there's lots of these out here. This is by no means the only one. Small, portable, compact, lightweight, used for short-term end-tidal CO2 monitoring. So it's great for transports, great for field. So there's lots of different things like this. Easy to maintain, no routine calibration. So those might be useful. I like that idea. It doesn't look like it gives you waveform. I like waveform, but there's whatever. Then the next one, let's go scuba diving. I don't know what's going on in that picture. The Porter nitrous oxide and oxygen system, obviously the guy in it is getting adequate nitrous. He looks pretty happy. I don't know what's going on with the other guy. I was very proud of myself in high school, in medical school rather, when people would take the night, they would have nitrous parties. Someone would be risking their entire education and career by stealing a nitrous bottle. But the big problem was when you have that nitrous bottle, everyone sucks on the nitrous, you're high for about 2 seconds while you're using the nitrous. So everyone else is sober looking at you unless they're doing something else, which is not that much of a party. But I discovered, having just completed my pharmacology course, that the route was the problem. So we then hooked the nitrous tank to a beer ball and bubbled the nitrous through the beer, replacing the head of the beer with nitrous. So now everyone could be having nitrous at the same time, and that works lovely. I'll just tell you, that works pretty well that way. But we don't have any of these things. I don't know what. I guess with that thing around his head, it means that you can't be using the nitrous for a facial procedure. So it can't be for that. You can't do a scalp wound or anything like that with it. Then we have the PenThrax single combo methoxyfluorine and inhaler. And they say that PenThrax is a non-narcotic inhalational analgesic. I'm interested in that. That gets my attention. You got it?
Our EMS in New Zealand uses that routinely.
Tell me about it.
It works great. They give them a little inhaler.
Anyone, other experiences? You guys?
They suck on it and it only lasts till
The Kiwis are keen. They're all in the front row.
Yeah.
Yeah? Did it now. Kept getting stolen. Who could imagine that? I mean, if they managed to get the big nitrous tanks out of the hospital without being seen, I'm pretty sure that thing's history. That's going.
Little single-use things, like they
Yeah.
get a cartridge.
Single use?
Like 20 minutes.
Now, what is it exactly that's happening with this guy in the lake? Is it only useful if you're halfway submerged in a lake? Anyway, we got a randomized, double-blinded, placebo-controlled trial of it, and they say the mean baseline pain score is decreased in 20 minutes, p-value 0.001, median time 4 minutes, 10 minutes. So if there is a really good inhaled narcotic analgesic, I'm interested in that. I, by the way, will regularly inhale fentanyl to people who have a super sore throat. I don't know if it makes sense to be applying the fentanyl to the sore throat, but I try it for the yucks with the Decadron, with the other stuff that I'm giving them. I think that works. I'll sometimes put some lidocaine in there. I do a little witch's brew. The respiratory therapist looks at me like I'm insane.
So if you guys use it, is there overdosage and still is there an antidote?
It's just a single dose, and they just hand the inhaler to people. Usually, well, we don't use it in the ED, it's just for EM.
For field.
Yeah, field, and it seems to work. I mean, fractures, all kinds of.
Clear, colorless liquid, characteristic fruity smell.
I don't really understand why it works, but it seems to work.
A vapor or gas once it has been poured into the PenThrax inhaler. And then, yeah,
But it doesn't put them out. It just helps them.
yeah.
It's just allergies.
Via the handheld PenThrax inhaler for pain. I'm interested in that.
Yeah.
That's,
You can't overdose on that.
you can't overdose because of the single dose.
Maximum
Yeah.
alcohol concentration.
And you don't need a scavenger hood. Right, a lot of those things, right? You try and use them in the emergency room. Oh, you don't have a scavenger hood. They drop it. So it's like nitrous. It's once, if you get too high, it falls out of your mouth. Yeah, all right. I like it.
Nitrous in the EDs. And
Yeah, you have the better nitrous. We use nitrous in ours, but they won't let us use it at over the 50-50, the wrong way, 70-30. So 30 nitrous, 70 oxygen. You know, it's regulation in the States. There you go. All right, how many of you have a Tonopen in your emergency department? So most everyone. How many of you have switched to the eye care Tonopen? Man, is it better or what? Yeah, that caliber. Don't you hate that when the Tonopen hasn't been used for a while? You're there like this. People are looking at you like, "What's wrong?" And you put the little condom thing on it, and you're doing it again, and it's driving you crazy. Then you're trying to do that thing. You can't get it in the right spot, so you're poking the eyeball, and you see the whole eye going, and you're not getting the beep, 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 And you're like, Jesus. Now it was better than the Shiats. I'll give you that. So the Tonopen was a major advance, but when compared to this eye care thing, which you brace on the forehead and think, no med, you don't even need to put the meds in the eye first because it's so quick. It's just a little quick pop. And it's just, so you get, this thing is, we had one, it was stolen. So yeah, it was LoJack too. It had the fake LoJack sign, gone. That means it was probably one of our people that stole it that knew the LoJack sign was fake. But I really think that's an improvement. You just got to chain it to the wall so that it can't go anywhere. The chain could be long. You could use it around the, but it has to be chained to the wall. Then, of course, someone will trip over the chain, and then there'll be a lawsuit, and they'll have to de-chain it, and then you'll be gone. Anyway. How about the diaton tonometer, which looks a lot like the Tonopen, but you can use it through the eyelid. You have it? No. I like the other one so much better that, I really think the eye care tonometer is, have you used it, Di?
Love it.
I really think that thing is the answer. It's so easy, it braces, gets it right, like ding, it's over, you're done. I like that a lot better than anything that looks like a Tonopen at this point.
How do you keep them from clenching their eyes closed? Do you have to hold their eyes open? Or
No, it's so quick, it just feels like a little puff. Poof. They blink when you do it, but it's done already.
and it really doesn't hurt?
No, even if you do it with you can do it on yourself. If you go to ASAP or one of the conferences where they have it, they'll do it to you with no drops in your eye. You'll be like, oh, puff. Super quick. Super quick, very easy, very reliable. You blink afterwards, but you're not even aware that it's apparently very reliable for the pressures. And then the SubQ stapler. So that's kind of interesting. Anyone got one of these? So I think there's a trend towards doing more and more stuff SubQ. Certainly from a cosmesis standpoint, there's an interest in it. Although staplers are not always the best way to get good cosmesis, really surgical skill is. This thing's $25, cheap, SubQ staples, SubQ skin stapler. I'm kind of interested in trying that one. I like that too. Closes wounds with absorbable subcutaneous staples. How long does a subcutaneous staple last? I got no idea. Right, we talk about what the time the absorbable stitch lasts, and it's, the minimum for the fast absorb stuff is like, 10 days to 2 weeks, and then the other ones are like a month. How long does a staple take to resorb? I don't know. I don't know. No one's used it? I'm interested in that too. I'd love to try that. I think that sounds fun. At $25, I'm ready to give that a whack just to see. So there's a couple things in here. I think they're entertaining. One of the things when we talk about widgets and gadgets is why are there so many? And I always quote Rick on this. Rick has said, Rick is very much an entrepreneur and a businessman and has done all kinds of widget inventing for medical records and this course and stuff. Rick has always said, you can live pretty well taking care of patients, but you can't be rich. But, taking care of patients won't make you rich, not 1% rich. So if you want to get rich in emergency medicine, there's really two ways to do it if it's going to be via emergency medicine. And one way, which unfortunately probably many of us are familiar with, is to exploit your colleagues. That's one way to get rich, become a contract holder, sort of move up the ladder, pay yourself more and more for doing less and less until you get paid everything for doing nothing. That's one way. And the other way is to provide things that are of service to your colleagues, which is, educational services, widgets and gadget services, and things like that. But emergency medicine, there's nothing like working nights when you're 50, when you get home, to have the creative energy to think of, I gotta be able to think of something else to do. So I think that and we're kind of creative, dialectic approach people, I think, by nature also in emergency medicine. There's that MacGyver instinct. And I think you add all that together, the night shift, the MacGyver instinct, the dawning of your 50th birthday, and you are an inventor. And that's why there's so many widgets in emergency medicine, I think, at least partly.